Morning, Paul. I know it was just over a week ago since we spoke on our initial information cast. We wanted to take up that really kind offer of yours of getting back in touch for an update. So, do you mind, Paul, just firstly, before we go into it, in case somebody's not heard the first information cast, your background and your expertise in pulmonary hypertension, and also why we're speaking to you in regards to the COVID-19 issue?
Certainly. Good morning, Ian. So I was, until recently, Professor of Thoracic Medicine at Newcastle. I directed the pulmonary service there, and I was also responsible for setting up, directing, and working on the lung transplant unit there for 25 years. Mm-hmm. I'm a respiratory physician or a lung doctor by training. And throughout my career, I was involved in the respiratory acute medical take. So I have a lot of experience in looking after patients with severe viral infections of the lung, bacterial infections of the lung, as well as my specialized area of interests in pulmonary hypertension and lung transplantation. And, of course, in the latter group of patients who are on immunosuppressive drugs to prevent rejection, I have experience in looking after immunocompromised patients with severe viral infections. So I think I tick most of the boxes.
Okay. No, that's excellent, Paul. That's wonderful. Just to move on, last week we talked more generally about COVID-19 and its infection and all those things. Can we be a bit more specific now this morning, Paul, about COVID-19 in the context of pulmonary hypertension, and probably in two areas? What's the current information in regards to the risk of contracting the condition, catching it, and then secondly, a much more probably difficult one, the severity of it, if that was to be the case?
Yes, I think we can. I think it's important to state right at the outset, though, that this is an evolving situation, and although I think it's totally appropriate to try and get a bit more focused, mm-hmm. This will be an evolving area, and I'm sure we'll return to it when there's a bit more clear evidence in a week or so.
Yep.
The first point to make, I think, is we have to be careful in what we're calling the underlying pulmonary hypertension problem. Is it pulmonary hypertension associated with left heart disease or respiratory disease? And that's the cause of the pulmonary hypertension, because that's one group of patients. Are we talking about pulmonary arterial hypertension patients with liver disease or congenital heart disease? Or are we talking about idiopathic and familial pulmonary artery hypertension? Because I think those three broad groups, there are slightly different bits of evidence and information.
So this information really is a general sort of picture that we're painting here.
Yeah, I understand that, but I'm trying to be as clear as I can.
Yeah.
So if I said the broad area, though, I think it's becoming clear that there is an increased risk of catching or a susceptibility to catching COVID-19 if you have underlying pulmonary hypertension of whatever the cause. I don't think it's clear exactly how much higher that risk is. And I think that uncertainty probably suggests that it might be a little bit less than, for example, someone with severe interstitial lung disease, such as lung fibrosis, or somebody with severe lung disease like COPD. It may be slightly less than that, although, as I say, the evidence isn't 100% clear. I think patients with CTEPH, particularly, they may veer more towards the group of patients with underlying lung disease. But again, very, very difficult to be absolutely 100% clear. But the take-home message would be, in terms of susceptibility, slightly higher risk than the average well person who's in isolation at the moment, but going out for walks and so forth. And I think we're awaiting, the PH community is waiting a directive as to whether that susceptibility is serious enough for patients with pulmonary hypertension to really isolate themselves for 3 months, which is, of course, what the advice is for patients with cancer or undergoing chemotherapy or transplantation or severe COPD and interstitial lung disease now, as of this morning. So if you're worried, 3 months isolation, but at the moment there's no government direction that way. What about if you've got pulmonary hypertension and you catch or develop COVID? I've been in touch with colleagues in the United States and throughout Europe. Just as a little aside, it may be relevant for the PH patients to know that the PH physicians community is communicating very effectively, and the Vascular Research Institute is about to sponsor a series of webinars where experiences can be exchanged. So the world is learning very rapidly from each other. So the first point is that it doesn't appear in many of the countries that if you have relatively mild pulmonary hypertension and relatively mild COVID-19, so that perhaps you can manage at home, as the vast majority will, you're not running into serious problems with the pulmonary hypertension. In other words, the heart is not developing heart failure at an excessive rate with mild COVID-19. Mm-hmm. What is clear, though, is at the other end of the spectrum, if you have severe pulmonary hypertension and you have or you're exposed to a very large dose of the virus and get a severe dose of viral pneumonia, you are more likely to develop what's called adult respiratory distress syndrome or a severe lung injury. And regrettably, more patients in that area will require transfer to an intensive care unit and advanced support to keep them alive before anticipated recovery in what we hope will be the majority of cases. But we need to watch this carefully.
And as you say, Paul, I mean, this is an understanding and knowledge that is evolving over quite a short period of time. And one of the reasons that we're able to do that, as you say, in the context of the world of PH, is that there's not only, as we talked about last week, national collaboration, there is international collaboration. The network is really a good interactive network, and again, that's really helpful and hopeful for the future.
Oh, yes. I think we learned a lot, actually, from the HIV situation many years ago. We learned that when there was a global issue, working together, we could be much stronger than working in individual silos. So when I checked the clinical trials registry this morning, there are, I think, 178 clinical trials of novel therapies for COVID-19 currently being undertaken on a world basis. And when you think, as I said last time, this is a virus and a disease that we've only really known about for 3 months. I think that's a pretty impressive response by the medical scientific community.
Yeah. So what was that number again, Paul? Just was it 109?
178, I think, listed trials, but it's probably now 190. This is again a very rapidly escalating area. Mm-hmm.
Okay, that's really helpful. Just going sort of moving back towards the present, what we do know, etc., is that one of the questions that we've had quite a lot through the PHA, and I know is of concern to people with pulmonary hypertension, that if somebody did require, somebody with pulmonary hypertension did require, and this is general advice, so, urgent medical help because of COVID-19, what might happen, do you think, in the present climate, and should they find themselves needing urgent attention, go locally rather than the PH centres?
I think they'll have to go locally if they're sick, and I don't think there may not be time to travel to the PH centre. Moreover, where the PH centre is located, they may not have as well a developed system of dealing with these patients as they come in, like the acute receiving hospitals. Each city and area will have a local plan, and so patients will end up, according to that plan, in the emergency receiving hospital designated for such patients. Mm-hmm. So I think there are a number of words of advice I would give to patients. Those receiving areas are going to be extremely busy, and they're going to be focused very much on COVID-19 and not the other underlying condition. So en route, you should be advising your local centre about what's happening and where you're going. The reason I say that is that if you wait till you get to that receiving area and then speak and say, can you ring the hospital that looks after me, there just may not be any practical time for doctors to do that. And I think it would be better for patients themselves to take on the responsibility of advising their centre, who can then contact the emergency centre and provide the information that they may wish to glean in terms of the management. And I'm thinking particularly of patients who may be either receiving intravenous prostacyclin therapy and, even more relevant, nebulized prostacyclin therapy. Mm-hmm. Because one of the ways of spreading COVID-19 from the lung very efficiently is via a nebulized system. And, of course, if you're inhaling a prostaglandin via a nebulizer, or potentially, if you are infected, even more infectious than you otherwise would be. And so there'll be a lot of anxieties about that. And, of course, the emergency receiving hospitals won't have much clue about what to do in that situation. And that's why it's essential to get your centre involved. And I would say that every centre, as a part of the standards that we introduced and are measured against on an annual basis, 24-hour, 7-day-a-week emergency advice should be provided by the centre. So you can access the centre through the numbers that you should already have, or through the hospital's switchboard, and speak to someone and get that right up there up front. And again, this should be, take that responsibility, please, yourself, because if you are hoping that will be done by the doctors who first see you, who are non-specialists in this area of pulmonary hypertension, in the acute receiving area of the emergency room, they just may not have time to go off and ring and dial and ask. Mm-hmm.
Yeah, that's very helpful, Paul. So, I mean, in essence, it's about being proactive in your own care and management, isn't it? And also, as you say, make sure that you've got in preparation the telephone numbers that you might just need in the future, rather than waiting for something sort of almost in a panic situation. And what do we do? So just make sure you've got the numbers and things like that. So being proactive and being part of the answer to what may happen. 100%
agree with you, Iain.
Good. One thing we did talk about last week, Paul, in our discussion was the and we talked about antibodies. and the role of antibodies. And we could you just again explain, as you did last week very clearly, what an antibody is, and whether antibody testing might be a part of an understanding of the present situation in the long term?
So an antibody is a protein that can be measured in the blood. It's developed when the immune system meets a challenge such as a virus like the coronavirus. And what happens is the immune system gets primed and produces in the blood this protein. The antibody protein can take part in getting rid of any subsequent exposure to the virus. So in other words, if you have COVID-19, get over it, you've then got antibodies in the blood that will protect you from redeveloping COVID or coronavirus infection, COVID-19 disease in the future. We don't know quite how long that immunity will last for, but at the moment it looks pretty good. And that's very important because once that test is available and can be applied to the huge population, we'll have an idea then of how many of the UK population have actually truly had COVID-19, because there are many people who will have had it without realizing it. We understand at this point they had very transient, mild illness. And so, of course, that will then give us tremendous information for public health as to how much of the population of the UK is now has got resistance against redeveloping COVID-19, and therefore it'll give you, as that number increases and increases, so the emergency pandemic will die out and we'll get back to normal. It's also very important for people, I guess, like me, who are about to return to the front line, and those working on the front line in hospitals, in that if you have the antibody test and you're positive, in other words, you've had a COVID-19 infection but have recovered, then you are protected against acquiring it from a patient who may be quite sick. But you can have it takes away the fear that you are at risk of developing serious illness yourself.
That's really encouraging. Paul, this is, as we've said right from the beginning, we'll continue to say, this is an evolving picture. At the present time, from your expertise and your many decades of experience, etc., and everything that we've just discussed, what would be your key message today to people with pulmonary hypertension?
Well, I think to follow the time-honoured guidelines that are being presented every day, and also to ensure that once a day you do visit government sites to see whether there's been any change. Don't avoid the news to find out on a daily basis what's happening. Those, I think, are important things. Isolation remains key and paramount at this point in time.
Absolutely. Yeah.
So that is the most. Don't pop round and see your mates. Don't stop to chat close to people if you have to go out or when you're going out to get your shopping. Observe the 2-meter rule. Stay inside unless you have to go out, as we've said, and still follow the hand washing and hygiene recommendations that were being put out right at the very beginning.
Yeah, excellent. Now, Paul, just before you go this time, you did say that you're going to go back to the front line.
I am.
What's your thoughts on that? What does that actually mean?
Well, I don't know yet, in the sense that I've volunteered to go back. I think there's an act of Parliament today that will grant me a 3-month temporary license. I'm still registered with the GMC, but I gave up my license to practice. That's required an act of Parliament to get back for everybody in my situation. and I've indicated a willingness to go back, and I think centrally to a central body that we're collecting the data, and then that information will be given and shared with the local hospitals, and then someone from the local hospital, my old hospital at Freeman Hospital, will be getting in touch with me and discussing where I can be best deployed. I think it's highly likely I'll be looking after PH patients that happen to be in, transplant patients that happen to be in, rather than staffing in an emergency room or the ITU. But I think at this point in time, I'm not clear. What I am clear is that I will be back in the hospital setting looking after patients.
Excellent. That again. I think that would be encouraging to lots of people. So hopefully, even in this busyness, if we may be able to catch up again in the near future, but also remembering that you as it were, going back to work. So I want to, once again, Paul, I want to thank you for your expertise, your time, your clarity, and as you said on a number of occasions during this conversation that we've had and last week, that things are evolving and people need to keep up to date. So as you said, the government website's one of the things that we do at the PHA. Our website is updated on a daily basis, and that's the links to those websites as well. So once again, Paul, many thanks from everybody at the PHA and the UK population with pulmonary hypertension. It's really it's encouraging, and it is reassuring in what are very difficult times for many people.
Not at all, my pleasure. Yeah, now is not the time to bury your head in the sand. Keep yourself informed on what's happening.
Okay. Thank you very much, Paul. Speak to you soon.
Bye.
Bye.